Assalamualaikum. Welcome to the first session of PSH. I'm honestly honored to start the first session as a moderator. And the first session is on hemoglobin disorders. And we have some very elite speakers in our first session. Our first speaker is Dr. Gulrukh Sohail, who is an MPhil hematologist. And now she's an FCPS2 trainee at Hyderabad Medical Complex at Peshawar. And she will be talking about molecular characterization and frequencies of different genetic ameliorating factors in transfusion-dependent thalassemia patients from district Peshawar. This is a free paper.
Assalamu alaikum. I'm Dr. Gulrukh Sohail. I'm going to present my research article, which is based on my MPhil thesis, title of which is Molecular Characterization and Frequencies of Different Genetic Ameliorating Factors in Transfusion-Dependent Thalassemia Patients from District Peshawar. Thalassemia syndromes are the most common genetic disorders worldwide, which causes significant mortality and morbidity. In Pakistan, thalassemia is an ongoing public health issue as well. An estimated 5 to 7% of our population is affected from beta thalassemia. On the other hand, the overall frequency of alpha thalassemia in our Pakistani population is 8.3%. Thalassemia is a heterogeneous group of genetic disorder, and a number of environmental and genetic ameliorating factors can modify the severity of the disease. The genetic factors which influences the severity of beta thalassemia includes the type of the beta thalassemia mutation, like the inheritance of the milder type of the beta mutation, co-inheritance of the alpha thalassemia along with the beta thalassemia, and presence of different polymorphisms which are associated with the increased production of hemoglobin F. All these ameliorating factors reduces the alpha-beta chain imbalance, and as a consequence reduces the ineffective hematopoiesis or erythropoiesis. HbF level is mainly regulated by 3 quantitative trait loci, which includes XMN1 polymorphism or C to T variation at position 158 on chromosome 11, HBS1L MYB intergenic region on chromosome 6, and BCL11A polymorphism on chromosome 2. Together, these 3 quantitative trait loci are responsible for the variance of the level of the HbF in patients with beta thalassemia or sickle cell disease or in the healthy individuals. In KP, a large number of the thalassemia patients exist, and here the local setup is such that patients are mostly diagnosed on the basis of their Hb electrophoresis without going for their genetic or molecular analysis. Hence, there's a likelihood to misdiagnose thalassemia intermedia and the thalassemia major patients. And very little work has been done on the local population of the district Peshawar regarding their molecular or genetic studies. So in my study, we screened the local patients of the district Peshawar for different genetic ameliorating factors in order to ascertain the severity of the genetic change. Hence, the objective was to assess the diagnosis of multi-transfused thalassemia syndrome patients and to determine the frequency of different genetic ameliorating factors among the study patients. Study design was cross-sectional descriptive study. Study settings include Institute of Basic Medical Sciences, KMU Peshawar, Fatimid Foundation and Blood Services Peshawar, and National Institute of Blood Disease and Bone Marrow Transplantation, Karachi. We enrolled 54 transfusion-dependent thalassemia patients from the Fatimid Foundation. Inclusion criteria was we took 54 registered patients of the Fatimid Foundation who possessed a valid and a verified HB electrophoresis report. And mainly the study was conducted on the pediatric age group up to 15 years of age. Patient with any active metabolic or systemic disease was excluded because that can influence the severity of the disease, and patients with thalassemia trait were also excluded. That was beyond the scope of our study. After the sample selection, a comprehensive questionnaire which encompassing the demographic and clinical data was filled out for each patient. Blood sample was collected and DNA was extracted. In the results, the mutations, known beta mutations were screened in the study population. These mutations include IVS15, frameshift 89, frameshift 41, 42, IVS11, deletion 619, CD15, CD5, CD30, frameshift 16, cap +1. These beta mutations cover almost 98% of the beta thalassemia mutations in Pakistan. Study patients were screened for the common single alpha gene deletions, that is 3.7 kb gene deletion and the alpha deletion 4.2. Patients were also screened for the XMN1 polymorphism and RFLP by RFLP PCR, and for BCL11A polymorphism, allele-specific PCR was performed. In the results, the 54 patients which were analyzed for the common alpha and beta mutations and deletions, beta mutations were identified in all 54 cases. The most common beta mutations which was identified in the study patients was frameshift 89, homozygous frameshift 89. Then homozygous IVS15 was observed in 9%. And then heterozygous IVS15 and frameshift 89 was observed in the 6%. 11 patients out of the 54 were found to have coexisting alpha thalassemia gene deletion, that is the alpha 3.7 gene deletion. Alpha 4.2 was detected in none of the patient. Here this pie chart showing the frequency of the alpha mutations. Out of the all 54, 11 patients were showing the alpha coexisting alpha mutation along with the beta. In out of the 54 patients, 2 patients had XMN1 polymorphism. That was heterozygous XMN1 polymorphism. None of the patients showed homozygous XMN1 polymorphisms, and 38 patients out of 54 had BCL11A. Here you can see that 2 patients out of 54 were showing the heterozygous XMN1 polymorphism, and 52 were negative for it. Out of 54, 38 showed BCL11A polymorphism, and in 16 patients, BCL11A was not detected. Only 13 patients out of 54 were found to have isolated beta globin gene mutations. As we discussed earlier, that ameliorating factors like the inheritance of the milder type of beta gene mutation, or the co-inheritance of the alpha along with the beta, and the presence of the different polymorphisms which are responsible for the increased HbF production. All these lessens the severity of the beta thalassemia disease. So in our study, we found that these ameliorating factors were found in about 85% of my study patients. Only 15% of the patients were without any ameliorating factor. And any patient which has more than one ameliorating factor is likely to have thalassemia intermedia. Presence of ameliorating factor in 85% of the study patients advocates the higher prevalence of the milder phenotypes in our local population. Hence, it was concluded that significant number of the transfusion-dependent thalassemia patients of district Peshawar carry coexisting genetic ameliorating factors. Identifying these ameliorating factors will help the clinician to have a better understanding of the disease severity, and this will also guide him in devising appropriate management plan for these patients. Thank you.
Thank you so much, Dr. Gulrukh. I think that was a very interesting finding, Dr. Gulrukh, that BCL11A was also assessed in the patients that you selected in your study. So I think that's a very important point, because a lot of laboratories they only do XMN1 polymorphism and they don't go towards BCL11A. So would you just tell us the clinical significance of BCL11A? Does it have any role in treatment of patients?
Basically, BCL11A increases the expression of the alpha globin genes, and it increases the production of the HbF. And as I said, that it reduces the alpha beta imbalance and the ineffective erythropoiesis. So by the presence of these BCL11A polymorphism in the patients shows that these patients are not purely major, and they have the lesser phenotype of the disease. So as what I think that the treatment or the management plan should be different from the treatment plan of the thalassemia major. They should be treated like the thalassemia intermediate patient. They doesn't require very frequent blood transfusions. As I noticed in Fatimid Foundation, that these patients, as I did a genetic study, and we found so many polymorphisms and coexisting polymorphism and the alpha co-inheritance, but they were labeled as a beta major there, and they were getting frequent transfusion, because of which they were getting splenomegaly, and as a result, the condition was worsening. So they should be, by this molecular study, these patients should be treated as intermediate, not as a major. Accurate diagnosis is required for the diagnosis of these patients.
Thank you so much, Dr. Gulrukh. It was a very good talk. And
thank you so much.
Thank you so much. So
thank
now
you.
I would.
Can I ask one question, please?
Oh, sure.
Can you please tell me that what percentage of your these thalassemia intermediate patients are in total beta thalassemia transfusion dependent patients? I mean, how many were truly transfusion dependent, and how many were these which you call them as thalassemia intermedia? What percentage are these patients whom you have analyzed genetically?
Sir, out of 54 patients, as I said, that only 8 patients were such that they were having just the beta mutation. Rest of the patients were having either one ameliorating factor or 2 or 3, and as I said, that presence of more than one ameliorating factor means that they are likely to have the thalassemia intermedia. So just 8 were purely beta major. Rest of all the patients were having milder type, like CAP+1 was also detected in the study patients, and coexistent, like XMN1 polymorphism was also present, alpha was also present. There were such patients that they were having 4 ameliorating factors. So by this study, we came to know that they are labeled as major, but presence of the ameliorating factor is like 3 or 4 means that they are not major. They are basically intermediate, but they are not diagnosed and treated properly. They are put on endless transfusions, and because of which they get so many complications due to that transfusion.
Wondering that did you in your study correlate your genetic findings with the phenotype? Actually,
Yes,
the patient
sir.
presents with
Yes, sir.
transfusion history.
Yes,
But
sir.
basically, the diagnosis of thalassemia intermedia is based on the clinical picture of the patient,
Yes, sir.
not the genetic profile,
Ji.
right? So what you have tried to do is that you have taken 54 patients
Ji.
and you have done the genetic analysis.
Sir,
And at any point, did you ever correlate the findings
sir.
of genetics with the
Yes, sir.
overall clinical phenotype of the patient?
Yes, sir. We correlated it with different clinical parameters, like with their transfusion frequency and their we looked for visceromegaly, serum ferritin, and
No, I'm just worried about the transfusion dependency,
Ji.
the transfusion history. How did they have a very severe disease, slightly less severe than that, or very mild disease? Well, this is how you actually classify them. So what was the actual clinical profile of these patients, these 54?
Sir, the anemia was, sir, not very severe, I can say, sir. They were having HB.
I think your findings will become very relevant and interesting if you try to correlate your genetic findings with the phenotype of the patients.
Yes, sir.
Out of the 54 patients, let's say if there were about 4 or 5 who had a milder disease, it probably would become relevant. Did they have any genetic correlating factor that actually supported the mildness of the disease or not?
Yes, sir. Sir, they were having HB between the 7 to 10. There were less number of patients were having HB less than 6 or 5. Sir, they were anemia was of moderate degree, and sir, but sir, as I said that they were presenting at early stage, maybe due to some intercurrent infections.
But I think it is important to know that how many had a milder disease and how many did not have a mild disease. That's important.
Yes, sir.
Just saying that patient had mild disease or not, I think this is not enough. If you really want to make your study very interesting, I think it will be very relevant that you go back to these patients, record their clinical findings, and then try to correlate the findings of the genetic profile with the actual phenotype of the patient.
Yes, sir.
It will become very, very relevant
Yes,
and an
sir.
important study. Thank you.
Sir. Thank you.
Thank you so much. Thank you so
And
much.
not only that, Suhaib, I think the importance that you have categorized them in 3 categories. It'll be interesting to look at which particular genotype goes with which particular phenotype.
Obviously.
Right. So now, I think, thank you so much for, it's a very heated topic right now, but we will, let's go on with the session, and we will take all the question and answers at the end of the session at the panelist time. So moving on to our next speaker, I think he needs no introduction, but I'll still take the time to introduce him. So our next speaker is Major General Suhaib Ahmed. He is very well known, and he has a very significant work on the prenatal diagnosis of thalassemia and other genetic disorders in Pakistan. He has also published a book with this title, and he has done his PhD in molecular genetics from University College London, and he has around 70 research publications concerning molecular genetics. He has also been the past president of PSH and the founding member of Association of Molecular Pathology in Pakistan. Right now, he's working as a professor of hematology at VIPA International University, Islamabad, and he also heads the Genetic Resource Center, Rawalpindi. His topic for today would be genetic counseling for hemoglobin disorders in local sociocultural settings. Thank you so much, General Suhaib. Please begin your talk.
Bismillah ar-Rahman ar-Rahim. First of all, I think I would like to thank the Pakistan Society of Haematology for giving me this opportunity to talk on this subject. I think it's a difficult subject, and I really had to scratch my head several times what to talk and what not to talk about it. Nevertheless, I think it's a very relevant subject, and being a hematologist for so many years, I don't think we have ever bothered to know about what's the role of NGOs in thalassemia in this country. Well, let me tell you that NGOs, they are the biggest stakeholders as far as thalassemia is concerned. They are, in fact, the biggest pillars. You would say that, you could even say that they are the MyBAP of thalassemia in this country. It's a very unique situation. And I don't think that anywhere else in the world there is a situation where such a massive problem is being handled by people who are not from the government, or if I'm allowed to say that most of them, they are not even from the hematologist community. Thalassemia is a hematological disorder, and we know that there are a large number of patients, at least 50,000 patients, or maybe more than that. And managing these patients, it's a lifelong problem. It's not just a disease that can go away with certain medicines. So this is going to stay for the rest of the life of the patient. So any family that is affected forever, almost, as long as the child lives. It has a tremendous burden on that family and overall on the health resources of the country. And it's rather unfortunate that it is being handled by people who are not professionally perhaps as competent as one would expect them to be. Well, let's talk about it. So whatever I am going to present here is based on my personal experiences of nearly 3 decades. And I'll be sharing with you what I have actually observed. Some of them, they are really commendable. These aspects are really commendable, but there are certain aspects where one really wonders that who is actually going to answer for these flaws and deficiencies. Well, as far as conflict of interest is concerned, you have to declare whether there is a conflict of interest or not. But I had actually inserted a small phrase here. Allama Iqbal का एक शेर है, मुझे है हुक्म अज़ां ला इलाहा इल्लल्लाह. तो जो कहना है मुझे वो मुझे कहना चाहिए, लेकिन मुझे मेरे कोलीग बता रहे थे कि ज़रा डिप्लोमेटिक होकर कहना चाहिए. चलें, आई विल ट्राई माई बेस्ट कि डिप्लोमेसी को भी उसका दामन भी ना छोड़ा जाए, बट फैक्ट्स को भी ना ओवरऑल किया जाए. Well, this is an approximate figure that 90% of thalassemia in this country is being handled by NGOs. And for those who do not know what is an NGO, NGO is a non-governmental organization which is registered as an organization, as a non-profit organization. They are not supposed to earn out of their whatever they do, and it's sort of a charity work. And maybe slightly more or less, maybe 5% plus or minus, public sector hospitals are also providing treatment facilities to thalassemics, but mostly it is the NGOs who are dealing with thalassemia. And fortunately, over 50 NGOs under one umbrella in this country. This is called Thalassemia Federation of Pakistan. I think this is a very, very powerful sort of a scenario or a platform where people from variety of NGOs from all over Pakistan, they have got together, and since 2003 they're working together on one platform. They have their annual meetings or biannual meetings, and they're supposed to have a uniform treatment protocol and uniform prevention strategy, and perhaps one national registry. But how far this is correct, I think this is another important aspect. They have a president. Well, I'm not here to really play the blame game, but let's face the reality that they have a very organized structure. President, Secretary General, who is very influential. In fact, both of them, they are very, very influential, very well known, and very sincere, I would say. Then they have executive committee, in which representation from every major NGO is almost there. And they also have advisory boards in which the technical people, they actually advise them on certain affairs. But unfortunately, very unfortunately, this body doesn't have a legal authority. If they have agreed to a uniform treatment protocol, then it's not possible for them to actually make it sure that people actually follow that. So that is the biggest flaw, that there is an advisory committee and there is everything, almost the entire structure is very impressive. But if they don't have a legal sort of authority, then it all becomes almost, I would not in fact say failure completely, but it becomes really very difficult to implement those strategies or those suggestions which are advised by different people in this federation. And the net result is, well, let me tell you this thing. This is the most unfortunate part. और इससे भी ज़्यादा बड़ा एक अनफॉर्चुनेट पार्ट है ये कि जो मैं आपको ये दिखाने लगा हूँ, दिस इज़ अ स्टडी विच आई हैव कंडक्टेड माई सेल्फ एट अ थैलेसीमिया सेंटर हेयर इन रावलपिंडी. और इसको देख के आपको थोड़े सा में भी शायद माथे पे थोड़े से कतरे पसीने के आ जाएं, लेकिन ये दीज आर रियलिटीज, दीज आर फैक्ट्स. और इसके पीछे भी एक और बड़ी इंटरेस्टिंग स्टोरी अटैच टू दिस. In early 90s, when I started doing my research on thalassemia, I had to collect samples from beta thalassemia major patients. And I contacted one of the NGOs, and they were reluctant to give samples of patients, as usual. And one day, in fact, I went to them and requested them that I need some samples. तो उन्होंने मुझे थोड़ी देर के लिए सजा के तौर पे या जो मर्ज़ी आप कह लो प्रोटोकॉल के तौर पे एक कमरे में बिठा दिया कि आप तशरीफ़ रखिए, अभी आपको हम इजाज़त देते हैं सैंपल लेने की. तो आई वाज सिटिंग देयर ऑल अलोन इन अ रूम डूइंग नथिंग. तो समझ नहीं आ रही थी क्या करूं. आई सॉ इन अ कॉर्नर देयर वाज अ फाइलिंग कैबिनेट लाइंग देयर. मैंने वैसे ही उसको खोल के देखना शुरू कर दिया. इट वाज अनएथिकल, लेकिन बहरहाल मेरे पास कुछ करने को नहीं था, तो आई स्टार्टेड सर्चिंग इन दैट filing cabinet. To my surprise, there were patient record files of those unfortunate patients who had actually died because of thalassemia. उसमें पड़ी हुई थी. उसमें मैंने देखा there were hundreds of files lying in there. So I just took out a few files and started scanning them. और सिर्फ दो चीज़ें मैंने नोट शुरू कर दी उसमें करनी. एक ये कि the age at which the patient died and what was the average hemoglobin that patient had during treatment. और उनको मैंने डॉक्यूमेंट किया. It was a very, very interesting finding. The average mean lifespan of a patient in those files was about 10 years. और ये एक ऐसी फिगर थी जो मैंने कभी नहीं पहले देखी थी किसी जगह भी, किसी ने कभी पब्लिश ही नहीं की इसको. और दूसरी चीज़ हीमोग्लोबिन. It was about 6.5 grams average mean transfusion, pre-transfusion hemoglobin. But a couple of years ago, I had the honor of being responsible for an NGO here in Rawalpindi who deals with thalassemia. तो वहाँ पर मैंने ये study organized तरीके से की. So this is what I actually got out of that. As you can see over here in this slide, on the left-hand histogram, this is the age in months of the patients who died because of thalassemia. And the mean lifespan is about 100 months. This is in spite of blood transfusions that they get. And the mean pre-transfusion hemoglobin is about, again, 6 to 7 grams per deciliter. Unfortunately, this is what it is. You go to any center of thalassemia in this country, you will find these two things. These unanimously present findings would be observed. And as far as iron chelation is concerned, half of the patients do not get any iron chelation. And those who get, that usually is in bits and pieces. It is not adequate. And there are different types of iron chelations which are given to these patients. Cost, of course, is and the net result of these bad treatments is that the patients are underweight and their height is stunted, the growth is stunted. So this is the sort of picture that comes out. You go to any NGO and their center, and even to government hospitals, you'll come across similar findings. It's very unfortunate, I think. And the survival plot, again, it's very poor. The average survival is about 84 months with treatment. Well, what is the reason for this? I think this is important. If we say that NGOs are actually taking care of 90% of thalassemia in this country, then they will also have to take responsibility of this outcome of thalassemia major. I think this is rather unfortunate. What are the reasons? Number one, I think हम अक्सर ही बात करते हैं that we are short of resources. Are we really short of resources? मुझे नहीं लगता है. I don't think so. It's not the shortage of resources. I think it is the disorganization of resources which is important. NGOs में resources की कमी मुझे नहीं लगता है. Many of them, they actually get hefty amount of donations, and how they actually spend it, उसको कभी किसी ने क्वेश्चन नहीं किया, कभी देखा नहीं है जाके उसको. और इसमें मेरे आई एम श्योर NGOs के रिप्रेजेंटेशंस मेरी प्रेजेंटेशन को सुन भी रहे होंगे. डॉक्टर शबनीज़, आप भी प्लीज़ इसको माइंड ना कीजिएगा. लेकिन मैं किसी एक ऑर्गेनाइजेशन की बात नहीं कर रहा हूँ. आई एम टॉकिंग अबाउट द जनरल ओवरऑल NGOs का जो प्रोफाइल है उसकी बात कर रहा हूँ. इसमें किसी एक NGO को हम सिंगल आउट नहीं कर सकते हैं. तो इट्स नॉट दी लैक ऑफ रिसोर्सेज, इट इज़ द डिसऑर्गेनाइजेशन ऑफ रिसोर्सेज विच आई थिंक इज़ देयर, एंड दैट नीड्स टू बी. उसके मैं बताता हूँ कि क्या सोल्यूशन हो सकता है. द लैक ऑफ यूनिफॉर्मिटी, ये बहुत एक और चीज़ है जिसमें यूनिफॉर्मिटीज़ तो है ही नहीं. कि हमारी किसी चीज़ में भी यूनिफॉर्मिटी नहीं है तो ट्रीटमेंट प्रोटोकॉल में कहाँ से होगी. अनफॉर्चुनेटली हमारा नेशनल एक प्रॉब्लम बन गया हुआ है. किसी भी जगह पे चले जाएं, हर एक की अपनी मस्जिद है एक, और वो उसी में खड़ा होकर नमाज़ पढ़ना चाहता है. द टेक्निकल सुपरविजन ऑफ दीज NGOs एंड देयर वर्क, जो बड़े शहरों में NGOs हैं उसमें तो टेक्निकल सुपरविजन मोर और लेस हो ही जाती है किसी तरीके से, लेकिन छोटी जगहों पे आप चले जाएं तो इट्स पैथेटिक है, बिल्कुल कुछ भी नहीं है. जो डॉक्टर्स भी नहीं है उन्होंने NGOs बनाई हुई हैं और वही उसको चला रहे हैं. एंड दे थिंक कि जी ब्लड ट्रांसफ्यूजन लगाना ही बस थैलेसीमिया का इलाज है, इसके अलावा तो कुछ नहीं है. और क्या कर सकते हैं जी हम, यही है बस हमारे पास. एंड दे आर नॉट आंसरेबल टू एनीवन. आई थिंक जब आप किसी को आंसरेबल ही नहीं है तो फिर आपने क्यों उसको ठीक करना है, कोई एफर्ट ही क्यों कोई करेगा. वेरी अनफॉर्चुनेट. कुछ ना कुछ तो इसका रास्ता निकालना ही पड़ेगा. नंबर वन, आई थिंक वी नीड टू रिकग्नाइज द प्रॉब्लम. जब तक रिकग्निशन नहीं होगी इसका सोल्यूशन भी नहीं निकलेगा. नेशनल थैलासीमिया अथॉरिटी, एक हेल्थ इज़ अ प्रोवेंशियल सब्जेक्ट, लेकिन प्रोवेंसेस के बिर अगर आप इंडिविजुअल हर प्रोविंस अपनी तरीके से इसको करना चाहेगा तो प्रॉब्ली दैट अगेन इज़ गोइंग टू बी रादर काउंटर प्रोडक्टिव. इसमें वी नीड टू हैव अ नेशनल थैलासीमिया अथॉरिटी हु शुड बी ऑथराइज्ड, जिसके पास लीगल अथॉरिटी हो कि अगर इफ़ देयर इज़ एन NGO विच डजंट बिहेव वेल, दे शुड हैव द अथॉरिटी टू एट लीस्ट give some sort of a punitive sort of action against that. और फाइनली ये भी होना चाहिए कि उसको या तो फंडिंग बंद की जाए या उसको बंद ही कर दिया जाए. मकसद ये नहीं है कि चीज़ों को ख़राब किया जाए, मकसद ये है कि हाउ टू इम्प्रूव द थिंग्स. Uniform treatment protocol. On papers, we have a uniform treatment protocol, but how to implement that on ground, I think, is another issue. जिसको वो National Thalassemia Authority should be able to ensure that. Then uniform prevention strategy, because we know that prevention is actually the solution for the thalassemia in this country, and we need to have a uniform prevention strategy. इसके ऊपर अभी बाद में बात करेंगे. Then technical supervision by hematologists and pediatricians. This is important, I think. इसमें generally MOs, you can't leave this problem to just MOs or simple MBBSs, and they try to do things according to their experience. We need to have at least hematologists and pediatricians involved in all major centers run by NGOs. Accountability, I think ये सबसे important है. Accountability, I wish कि इसके ऊपर कुछ किया जा सके कि people who are dealing with thalassemia, ये बड़ी serious problem है. एंड आउटकम मैंने आपको दिखा दी है जो भी है. उनकी एवरेज लाइफ स्पैन अगर 10 साल है एक बच्चे की, तो उसको आप ट्रीटमेंट क्यों दे रहे हैं आप, अगर उसकी मिजरी को प्रोलॉन्ग आपने करना है 10 साल के लिए, एंड द मिजरी ऑफ द पेरेंट्स एज वेल. तो आई थिंक आई हैव सीन पेशेंट्स being treated with blood transfusion and iron chelation, and they're growing up into their 30s, 40s, 60s and having their children. ये all over the world. लेकिन हमारे चूँकि मैसिव प्रॉब्लम है तो इसमें अकाउंटेबिलिटी के बगैर ये इट्स वेरी अनफॉर्चुनेट. और इसका टेक्निकल ऑडिट तो ऑब्वियसली ये सारा कुछ इट शुड बी डन बाय नेशनल थैलेसीमिया अथॉरिटी. एंड प्रिवेंशन एंड NGOs, ये स्लोगन है या अल्लाह मेरे मुल्क को थैलेसीमिया से पाक कर दे. ये स्लोगन वो है जो सब NGOs दिन रात इसका डंडोरा पीटती हैं. वेरी अनफॉर्चुनेट. ठीक है, अल्लाह ताला के पास है सब कुछ, लेकिन वी आर द पीपल हु एक्चुअली हैव बीन गिवन द रिस्पॉन्सिबिलिटी टू इंश्योर कि थैलासीमिया से पाक हो जाए ये मुल्क, और उसमें हम नहीं करेंगे तो कौन करेगा फिर? स्क्रीनिंग में ऑल NGOs दे क्लेम दैट दे आर डूइंग वर्क ऑन थैलासीमिया प्रिवेंशन। कहाँ करते हैं? टेबल के नीचे बैठ के करते हैं, उसके ऊपर बैठ के करते हैं, ये तो जाके पता लगता है आपको जब उस NGOs में जाते हैं। ओनली अ फ्यू हैव देयर ओन स्क्रीनिंग फैसिलिटी अनफॉर्चुनेटली। ये भी बड़े शहरों में बड़ी बड़ी बिल्डिंग्स बनाई हुई उन्होंने, और उसमें ट्रीटमेंट सेंटर्स हैं जिसमें ब्लड कलेक्शन बहुत अच्छी है। हाँ, ये ब्लड कलेक्शन पार्ट इज़ द बेस्ट पार्ट ऑफ इट। दे आर रियली वेरी एफिशिएंट इन कलेक्टिंग ब्लड बिकॉज दीज सेंटर्स रन ऑन ब्लड। इफ़ दे आर नॉट एबल टू कलेक्ट ब्लड, एडिक्वेट अमाउंट ऑफ ब्लड, तो फिर उनके पास कोई नहीं आएगा। पेशेंट्स आते ही तब हैं जब ब्लड अवेलेबल होता है। तो उन्होंने वो पार्ट तो बहुत अच्छा किया हुआ है। डोनेशन इकट्ठी करने का पार्ट भी काफ़ी अच्छा है, उसी के बेसिस पे बिल्डिंग्स खड़ी हो जाती हैं। बट हाउ यू एक्चुअली गिव दैट ब्लड, वो तो मैंने आपको अभी दिखा दिया हाउ दे गिव इट। 6 ग्राम हीमोग्लोबिन पे अगर ब्लड आप लगाएंगे तो बच्चे की लाइफ तो आप उसकी मिजरी प्रोलॉन्ग करेंगे, उसकी लाइफ को प्रोलॉन्ग नहीं करेंगे आप। अनफॉर्चुनेट है। प्लीज़ एक्सक्यूज़ मी अगर मैं ज़्यादा अनडिप्लोमेटिक होता जा रहा हूँ, मेरी आदत है। लेकिन बहरहाल इसके अलावा और क्या है तरीका हमारे पास? अगर किसी के पास से ज़्यादा पोलाइट वर्ड्स हैं तो प्लीज़ कम फॉरवर्ड एंड टेल मी हाउ टू एक्चुअली एक्सप्रेस दिस फ्रस्ट्रेशन। वेल, प्रीनेटल डायग्नोसिस इज़ द पिलर ऑफ प्रिवेंशन। स्क्रीनिंग जो है ये इस पे कभी किसी और सेशन में शायद बात होनी चाहिए, लेकिन स्क्रीनिंग इज़ मेरे ख्याल के मुताबिक बहुत इम्पॉर्टेंट नहीं है इस मुल्क के लिए, क्योंकि हमारी स्क्रीनिंग आप अगर पॉपुलेशन को कर भी लेंगे ना तो थैलासीमिया प्रिवेंशन उससे होगी या नहीं होगी, ये बहुत बड़ा क्वेश्चन मार्क है इसके ऊपर। तो लेट्स नॉट स्पेंड टू मच ऑफ मतलब मनी एंड एफर्ट ऑन स्क्रीनिंग अलोन। प्रीनेटल डायग्नोसिस, ये दिस इज़ द कॉर्नर स्टोन ऑफ प्रिवेंशन ऑफ थैलासीमिया इन दिस कंट्री। लेट मी टेल यू, अगर मैं आज हूँ यहाँ पर बैठा आपको बता रहा हूँ, कल को नहीं होगा, तो प्लीज़ रिमेंबर दिस कि अगर थैलासीमिया इस मुल्क से ख़त्म किया जाएगा तो इट विल बी डन थ्रू प्रीनेटल डायग्नोसिस। मैसिव इसमें डिक्लाइन आएगा आपके बर्थ रेट में। Fatimid Foundation Karachi, they have established a center for prenatal diagnosis. I know it because I was actually instrumental in development of that lab. और उसमें मैंने in fact I am proud to say that I gave them a long list of equipment and which is still operational and they are doing a lot of prenatal diagnosis का काम है। डॉक्टर शबनीज़, थैंक यू वेरी मच, आपकी ऑर्गेनाइजेशन ने इसको अलाउ भी किया और इट इज़ रनिंग वेल। उसमें कुछ थोड़ी सी प्रॉब्लम्स आती रहती हैं दरमियान में, तो वी रिमेन इन टच। दे आर डूइंग अ वंडरफुल जॉब एंड दे आर डूइंग इट फ्री। आई थिंक ये एक एग्जांपल है जो सबको फॉलो करनी चाहिए। ऑल NGOs शुड फॉलो दिस। फातिमिद के अपने सेंटर्स हैं, पेशावर में है, लाहौर में है, मुल्तान में है। दे शुड एक्चुअली एस्टेब्लिश प्रीनेटल डायग्नोसिस सर्विस इन दीज सेंटर्स एज वेल। Umair Sana Foundation in Karachi, they are another one who claim that they are an NGO and they are offering free prenatal diagnosis service. लेकिन मुझे दाएं बाएं से ये भी पता लगता रहता है कि they also charge money from different patients. बहरहाल ये उनका अपना मामला है, लेकिन at least it's commendable that they have a service for prenatal diagnosis of thalassemia. Others, बहुत सारे लोग दे क्लेम, लेकिन आई थिंक दे आर देर इम्पॉर्टेंट। NGOs का एक बहुत इंपॉर्टेंट रोल है कि मेरे पास जैसे प्रीनेटल डायग्नोसिस करवाने के लिए जो पेशेंट्स आते हैं, मोस्ट ऑफ देम दे कम फ्रॉम NGOs एंड आई एम रियली थैंकफुल टू देम दैट दे एक्चुअली अलाउ देयर पेशेंट्स टू कम टू मी। और ये भी बड़ी बात है, ना वो अलाउ करेंगे तो कौन उनको पूछ सकता है। तो बहरहाल इसमें आई थिंक अब कितनी मैं इसको और पैथेटिक बात करूँ इसके ऊपर, ये दिस इज़ अ स्मॉल एक्सपेरिमेंट मैंने किया ऐसे, ये कोरोना आने से पहले, आई थिंक 2 साल हो चुके हैं अब तो इसको। ये लंबी एक लिस्ट है NGOs की, मैं ये नाम इसलिए लिखे हैं कि ये लंबी लिस्ट है, ये इसलिए नहीं कि मैं किसी को पॉइंट आउट करना चाहता हूँ। ये जो आपको तस्वीर में नज़र आ रहा है ना, ये वो जहेज़ का सामान है। ये एक लैब है पूरी, जो मैंने इन सब NGOs को अपने पास बुलाया। आई कंडक्टेड अ वर्कशॉप, आई टोल्ड देम हाउ टू यूज़ दिस इंस्ट्रूमेंट। दिस इज़ एन इंस्ट्रूमेंट दैट आई हैव डेवलप्ड माई सेल्फ। दिस इज़ यूज्ड फॉर स्क्रीनिंग ऑफ थैलासीमिया एंड इट्स वेरी लो कॉस्ट। वन टेस्ट on this equipment costs about 50 rupees or even less than that. और इन सब NGOs को ये फ्री ऑफ कॉस्ट इंस्ट्रूमेंट्स मैंने सारे पैकेज के तौर पे दिए और बड़ी खुशी खुशी ले गई है सब। उसके बाद कुछ अर्सा तक मैं इनको वेट करता रहा कि नो दे विल एक्चुअली स्टार्ट यूजिंग इट। कभी कभार मैं पूछ भी रहता था कि हाउ इज़ इट, ओ जी हम अभी इसके लिए जगह ढूंढ रहे हैं, कहाँ रखें इसको जाके। तो दीज वर द टाइप ऑफ आंसर्स दैट आई यूज़ टू गेट। एक को ज़रा मैंने सख्ती से पूछ लिया कि भाई आप करते क्यों नहीं इस पे काम, तो वो आगे से मुझे कहता है कि आप इसका इशू बना रहे हैं। जस्ट इमेजिन कि चीज़ आपको मुफ्त दी गई है, और आपको वो इस्तेमाल नहीं करनी आती, और उस आप आगे से बजाय इसके कि ये कहें कि जी हमें आप मज़ीद कुछ और इस पर सहूलत पैदा कर दें, तो वो आगे कहता है आप इसका इशू बना रहे हैं। बहरहाल बहुत सारे सवाल आते हैं, तो टू कट शार्ट इन सारी लिस्ट में से मेरे ख्याल में 1 या 2 में भी शायद 3 ऐसे सेंटर्स होंगे ना जिन्होंने इसको थोड़ा सा यूज़ किया। अदर्स हैव जस्ट केप्ट इट देयर, मे बी दे वुड लाइक टू शो इट टू पीपल कि जी हमारे पास ये सामान है, ये दिस लैब इज़ देयर। एंड सॉरी मैंने ज़्यादा लंबा कहीं दिया, आई विल जस्ट ट्राई टू बी ब्रीफ। प्रिवेंशन एंड NGOs में एटलीस्ट 25,000 रजिस्टर्ड पेशेंट्स तो हमारे पास एक्सेस है उनकी, एंड we can screen their families. I think NGO का बहुत बड़ा प्रिवेंशन में रोल हो सकता है if we allow, if we actually try to work with them. Thalassaemia centers of NGOs should be the center of prevention activities. This is my strong recommendation. जो prevention program में involved हैं उनसे भी, it's my very humble suggestion. मैं सुबह एक एग्जांपल आपको दे रहा था, ये हमारे कोलीग्स जो बाहर बैठे थे, कि जो अगर आपने कपड़े की दुकान खोलनी है तो आप कपड़े की मार्केट में खोलेंगे तो फ़ायदा है, अगर बाहर कहीं खोलेंगे तो कपड़ा कम बिकने का चांस है। इफ़ यू वांट टू डू प्रिवेंशन ऑफ थैलेसीमिया देन इट शुड बी डन एट सेंटर्स ऑफ NGOs। आपको अलग इंफ्रास्ट्रक्चर बनाने की ज़रूरत ही नहीं पड़ेगी, उनके पास जगह है। यू सिंपली शुड बी एबल टू प्रोवाइड देम वन सिंपल, जो थोड़ा सा मैन पावर चाहिए, 1-2 लोग उनके पास, बाकी रेस्ट यू कैन यूज़ देयर पेशेंट्स। So it will be most interesting and logical to actually use their infrastructure. We need to strengthen the NGOs, employ training, manpower and everything. I think provision of equipment and kits, वो आप कर सकते हैं, and I've given you an example, low cost solutions are available. Monitoring and evaluation I think is important. फंडिंग, लेजिस्लेशन की बात अक्सर होती है थैलेसीमिया प्रिवेंशन के लिए। मेरे ख्याल में अगर कानून बनाया जाए इस मुल्क में तो एक तो ये होना चाहिए कि जो NGOs हैं उनका जो फंड है उसमें से कम 10% हिस्सा इट शुड बी डेडिकेटेड फॉर प्रिवेंशन। ठीक है जी, हुकूमतों के पास बहुत सारे पैसे हैं, ये अक्सर वो लोग बड़े प्राउडली कहते हैं जी कि हमारे पास तो बहुत पैसा है, हमारे पास तो ये है वो। आपके पास कानून का ख़जाना भी वो ख़त्म हो जाएगा अगर आप उसको बेवकूफ़ों की तरह इस्तेमाल करेंगे। लेकिन अगर आप उसको वाइजली इस्तेमाल करेंगे और कोई कानून के मुताबिक इस्तेमाल करेंगे, NGOs को इंश्योर करेंगे दैट दे बिहेव वेल, तो फिर आपकी प्रॉब्लम जो है वो बहुत आसान हो जाएंगे। एंड आई थिंक थैलेसीमिया फेडरेशन ऑफ पाकिस्तान के ऊपर बहुत बड़ी रिस्पॉन्सिबिलिटी है। दे नीड टू, थैंक यू वेरी मच फॉर रिमाइंडिंग इन टाइम। And this is all about the role of NGOs. I hope कि I've been able to communicate well and किसी को मैंने बहुत ज़्यादा offend नहीं किया। और and if someone has been offended, I'm really I would like to apologize for that. And if there are questions or comments, welcome to ask, or maybe at the end of the session you can ask the questions. Thank you.
Thank you so much, General Suhaib. It was an enlightening talk, and we are forever grateful for your services for this country, I guess, on a nationwide level. And we'll always remain grateful to you. So now we'll take the questions and answers at the end of the session, as General Suhaib just mentioned. So now I'll be introducing my next speaker, Dr. Shabnam Bashir. She is the Associate Professor of Pathology at FJMU and a Project Director for Punjab Thalassaemia Prevention Program. Her main work, her area of special interest is in hemoglobinopathies, and she established successfully thalassemia prevention services across Punjab. Right now, she is currently she's doing an international joint research work with Leeds University, which is a funded project, and she's also a co-primary investigator of an international hemoglobinopathy working group. She will be presenting on Provincial Thalassaemia Prevention Program. Please, Dr. Shabnam, you can begin now.
Thank you very much, Shabneez, for this introduction. I'm very grateful to the organizers for giving me this opportunity to showcase my Punjab Thalassaemia Prevention Program on this prestigious forum. And today, I'm really very happy that, in my opinion, sitting in the audience of General Suhaib, that it is a landmark day कि actually उन्होंने जो बिल्ली थैले में से बाहर निकाल दी। मैं एक्चुअली हम जब ये बात करते हैं कि हमारे यहाँ थैलेसीमिक्स इतने अच्छे मैनेज कर रहे हैं कि केटू की पहाड़ियों पे चढ़ रहे हैं और उसके अलावा वो नौकरियां कर रहे हैं, शादियां कर रहे हैं, बच्चे पैदा कर रहे हैं, दिस इज नॉट द गोल्डन सिनेरियो दैट एवरीबॉडी इज पोर्ट्रेइंग। जो हालात उन्होंने दिखाए हैं वो उतने ही पैथेटिक हैं और इट्स हाई टाइम कि हम इस चीज़ को ऑन करें और एक्चुअली जो इसके जो रिमीडियल एक्शंस हैं, इवन दो इट्स क्वाइट लेट, अभी भी इतनी देर नहीं हम उसको दोबारा एक रास्ते पे ला सकते हैं. So these are the statistics that we are familiar with, the prevalence, the incidence, the huge burden, the plight and the misery of these patients, and the actually money which is needed for the optimal treatment of these patients. And throughout Pakistan, not a single center is treating them optimally. So the prevention is the only viable solution which is doable, which is cost effective. There are many researches to prove that, and successful models around the globe. So even though we can't really say कि around the globe के साथ हम अपने आप को align कर सकते हैं, क्योंकि हमारे यहाँ जो हमारी problems हैं बहुत uniquely different हैं और difficult हैं. अगर आप सिर्फ blood transfusion services को ही ले लें और जो हमारी screening methodology ले लें, इन चीज़ों को ही ले लें, तो हमारी but still there are successful models, and one of the model that I'm going to present to you is the पंजाब थैलेसीमिया प्रिवेंशन प्रोग्राम. एक्चुअली हमने अभी तक ये तो क्लेम नहीं कर सकते कि हम अपनी जो कैपेबिलिटी और जो एफिशिएंसी है वो 100% है, बट एटलीस्ट वी आर ट्राइंग टू मूव इन दैट डायरेक्शन. So basically this project was formulated 2009 and ended on 2017, and then phase 2 from 2017 and to June 2020. So both of these phases, they are completed, and by the evaluation of the DG monitoring, it is the most successful intervention around for prevention of thalassemia in the country, and we have achieved all our specified targets in our PC1. So basically this is the project network, and again it is working on same hub and spoke model, जिसमें एक center है PIMU in सर गंगाराम हॉस्पिटल and satellite units हैं. Initially जब मैं इसकी project director बनी थी तो हमारे पास दो इसके regional labs थी, एक लाहौर में और एक रावलपिंडी होली फैमिली हॉस्पिटल में. But with the passage of time, in mere 5 years, we have got now 9 fully equipped regional labs in 9 divisions of Punjab. तो इसमें ये है कि हमारी जो सदर्न पॉपुलेशन है उसके लिए हमारे पास 3 रीजनल लैब है, निश्तर हॉस्पिटल में, डीजी खान में और साहिवाल मेडिकल कॉलेज में. फॉर सेंट्रल पंजाब वी हैव गॉट रीजनल PIMU इन सर गंगाराम हॉस्पिटल, देन फैसलाबाद मोहम्मदाबाद हॉस्पिटल एंड DHQ गुजरांवाला, और नॉर्दर्न पंजाब के लिए होली फैमिली के अलावा सरगोदा के अंदर हमारी रीजनल लैब्स हैं. इन सब रीजनल लैब्स के साथ हमारे डिस्ट्रिक्ट्स 36 डिस्ट्रिक्ट्स हैं वो अटैच किए हुए हैं, और जितनी भी सर्विसेज प्रिवेंशन की है थ्रू दीज रीजनल सेंटर्स, दे आर इम्पार्टेड टू दी एट डिस्ट्रिक्ट लेवल. ये हमारा जो PIMU है, जो सर्विसेज हम प्रोवाइड कर रहे हैं, बेसिकली ब्लड कलेक्शन फॉर कैरियर स्क्रीनिंग एंड अदर टेस्टिंग, जेनेटिक काउंसलिंग, carrier screening by CBC and HPLC and capillary zonal electrophoresis, and chorionic villus sampling of prenatal testing. This is strongest point that we mastered, that we are doing now CVS in 8 regional units of Punjab Thalassemia Prevention Program across Punjab. जिसमें हमने गायनेकोलॉजिस्ट को ट्रेन किया, हमने 20 के करीब गायनेकोलॉजिस्ट ट्रेन किए हैं जो उस रीजनल सेंटर के अंदर कोरियोनिक विलेज सैम्पलिंग परफॉर्म करती हैं, और सिर्फ DNA का सैंपल जो है वो रीजनल लैब लाहौर को रिसीव होता है. और ये सारी एक्टिविटीज हमारे सारे रीजनल लैब्स के अंदर हो रही हैं. हमारा जो फील्ड स्टाफ है डिस्ट्रिक्ट्स के अंदर, 36 डिस्ट्रिक्ट्स के अंदर, वो एक्सटेंडेड फैमिली स्क्रीनिंग की सर्विसेज डोर स्टेप पे जाके देता है, और वहां से सैंपल कलेक्शन के बाद वो वापस रीजनल लैब को आता है, और जो रिपोर्ट है वो वहां पे तैयार होती है, और उसके बाद फिर वो रिपोर्ट जो सी है बैक टू दी DHQs. जो सर्विसेज हम प्रोवाइड कर रहे हैं, दीज आर नॉट ओनली फॉर थैलेसीमिया बट ऑल सॉर्ट्स ऑफ हीमोग्लोबिनोपैथीज थ्रू आउट पंजाब, and the prevention we are doing this through awareness, carrier detection, prenatal diagnosis and genetic counseling. So this is the number of the carrier screening that we have done in last 6 to 7 years, and you can clearly see that from 2015 onwards there is upward trend in the graph, and we have done more than 2,35,000 carrier screening for the individual, and I think it is one of the largest screening data available across the globe. And in last year, again due to the COVID pandemic, we stopped our extended family screening. That is why number is slightly low, but still we have achieved main part of our target. This is regarding premarital screening, which is still in mandatory mode in Punjab. We have done this much number. Genetic counseling, you can see the trend. Again, prenatal diagnosis in PTPP, PIMU, we are imparting by chorionic villus sampling, and analysis that we do is by ARMS PCR, and we also optimize the reaction of real-time PCR, which we are doing by the techniques of high-resolution melt curve analysis and TACMAN Pro-based assays. Again, Alhamdulillah, this year we have also optimized gap PCR for alpha thalassemia, and we are routinely doing this. And we also optimized the detection of alpha thalassemia mutations by HRM method. And we are also doing VNTR markers in those cases where the need is required. You can see the chart of prenatal testing. Yearly, we are doing more than 1,000, but the requirement to actually control the disease is quite high, maybe 10 or 20 times more than that. But despite COVID-19, in year 2020, we have achieved this target, not only achieved it, but we surpassed it. 1,128 CVS were done in this difficult year as well. So this is the revamping of Punjab Institute, Punjab Implementation and Monitoring Unit Lahore, that we have got a very state-of-art modernized sort of setup in Gangaram Hospital. The other very important achievement that I really cherish is IT proficiency. What is that all our reporting, it is done in real time, and it is a cloud-based system. And the reporting is done here in Lahore by a consultant hematologist, and it has got the patient registration module, in which again we are maintaining our own registry as well. There is barcoding and traceability of the samples, the interfacing of CBC and HPLC machines, so human errors are less and less. It is a web-based centralized reporting system, and it actually shortened the turnaround time of months to less than 1 week in most of the cases. And we have got a live dashboard in which we can see our progress. And this is maintained by Punjab IT Board. So this is a software. First, the CBC report is received by the consultant hematologist, and if they can give a non-carrier verdict on CBC, it is just given. But if it requires the further testing by HPLC or capillary zone electrophoresis, we forward it for HPLC. And there are some cases which again require the molecular diagnosis. So this software is being handled by a consultant hematologist present in Lahore, and all the regional labs, they are connected with this centralized reporting system. So this is a live dashboard, and since when it is operational, we have done more than 150,000 cases on this live dashboard, representing all 36 districts of Punjab. So some achievement that we made in as far as the thalassemia registry is concerned, I know and we all know that this is the most important step in which, when we realize what is the actual burden that we are talking about, what is the actual incidence of the disease now, and maybe after say 5 or 10 years, when we are going to actually reduce that burden of disease. So in order to document that decline, we need this thalassemia registry. And these on this registry, we have taken on board all healthcare facilities, both in public as well as private sector, including NGOs treating thalassemia patient, and they are going to register their patients on this web-based universal registry. And it has been started simultaneously in all 36 districts of Punjab. And I am going to share with you my beginning and my progress, and I'm going to keep on sharing it with time to time. So this is the just the elementary or basic info that we are now getting. We have got 3 modules. One is the registration module, one is for the clinical and the lab data, and third is the treatment and the complication module. But right now what we have activated is just the registration module, because this is doable for the time being, and it contains only the name and the father's CNSE, and there is a check on father's CNSE. So there won't be any duplication in any of the NGO. And if a family has got more than one patient, which is the scenario in many cases of thalassemia major children, then we are going to collect the information in hard form, and we are going to introduce those cases in this portal from the center. So there is a check on father CNSE, and we are just getting the basic information given in these two forms, just their demographic data and important info. So this is the card that we are going to, at the end of like next 6 months or so, all the thalassemia major cases in Punjab are going to have a card like this, in which their MRN number is given. And in the latest version, we have also added a unique password for each and every patient. So the basically the sensitive data for that patient is secure, and only those who are given that password by the individual patient himself is going to have the access to all the information. Otherwise, with the MRN number, we can only access the basic demographic data and the status of the patient. So in order to see that whether this thalassemia registry software is workable, first we did this a pilot, and this pilot has been done in 4 regions. In Jamila Sultana Foundation Rawalpindi, in Thalassemia Center Bhawal Victoria Hospital, in Rahim Yar Khan Sheikh Zaid Hospital, and in Sir Gangaram Thalassemia Society of Pakistan NGO, their center. And we successfully enrolled all their individual cases in our registry software, and it is an ongoing process, and new cases, when they encounter them, we actually get them on our registry as well. After doing this, the second phase was very difficult, because as we all know that these NGOs, they are, even though are there, but as far as their data approach is concerned, it is very tricky and difficult to get access to their data. In order to have that, we actually approached our specialized healthcare, and we got permission from them and recommendation from them that all the NGOs should give their or share their data with us, and then we ensured these NGOs that their data is going to be safe with us. We are not going to share it with anybody else, and on that condition, they actually then decided to come along with us. And the second phase again was difficult, because in order to have this registry in place, all the NGOs, and the NGOs have got a very wide spectrum. There are some NGOs which are just one room with the transfusion facilities, and then there are NGOs like Sundas and Fatimid with their own centralized data collection setup. So what we did is that many of them, they do not have the required hardware in order to have this registry component. So what we decided in the next 2 months, that as we have stopped this extended family screening, our field staff is now available for the entering of this data in the registry. So what we did is that we identified 48 treatment centers across Punjab who are giving the treatment for thalassemia. We created their logins, and our own field staff is now trained, and this field staff in the even at the district level are going to these NGOs and registering their patients on their behalf. And in a very short time, I think around by the end of 2021, I am very hopeful and confident that we are going to have this at least thalassemia registry in Punjab, inshallah. So already in Lahore and in all the 36 districts, we have started taking these patients in all the NGOs on our portal. And you can see the number just taken in last week in basically in Lahore Center. There are many training programs that we are conducting in the field of hematology, prenatal diagnosis, and genetic counseling. International collaborative work doing with the University of Leeds, as well as with Inherent or International Haemoglobinopathy Working Group, especially regarding the genome-wide association study. A very interesting short paper was presented here, and we are actually working at a very advanced level on these genetic modifiers in thalassemia major and intermediate. So there are many poster presentation and oral presentations. These are the number of the publications from under the banner of Punjab Thalassaemia Prevention Program. And the way forward is right now we are in a transition phase in which what I understand from the last 5-year experience is that thalassemia is not going anywhere in next many decades from Pakistan. And in order to have a comprehensive and ongoing service, we have to come out of this development mode into a permanent non-development mode. So due to the efforts of Punjab Thalassaemia Prevention Program and of course Minister for Health, Professor Yasmin Rashid. Now we are going to be converted into an allied institute with Fatima Jinnah Medical University with the name of Institute for Prevention and Research of Haemoglobinopathies and Other Genetic Disorders. So we are in the transition, and in next month or so we are going to get the notification from CM, and inshallah we are then going to be working on a wider scale throughout Punjab. Then thalassemia registry. This is one single thing which we are very serious this year, and inshallah by 2021 we are going to have this thalassemia registry in Punjab at least. And ISO accreditation is the final step. No lab should work without that, and this is our dream. Thank you very much. And the take-home message here for all the consultants and hematologists listening to me right now is that, as General Suhaib rightly pointed out, prevention is the only viable solution in this country, and it is doable. International models, and you have got this very good example in the form of Punjab Thalassaemia Prevention Program. Come study it, and I tell you this is really doable, and we can do it in other provinces as well. And again, we should do it under the umbrella of a national. Thank you very much.
Thank you so much, Dr. Shabnam. It was a very enlightening talk, and I think it's an amazing work that you have done. Started an online registry for thalassemic patients, and I think the whole country should be adopting this this methodology of having one registry for the whole country. So thank you so much for your talk, and I'll be inviting Dr. Suhaib Ahmed for the next talk, and this talk is on genetic counseling for hemoglobin disorders in low socio-cultural setting. General Suhaib.
Bismillah ar-Rahman ar-Rahim. Well, I'm here again, and I was told कि जी आप उर्दू में बात ना करें. Please try to communicate in English. But I was just wondering, when you have to wash your dirty linen, you don't do it in public. So sometimes you have to use deliberately a language which probably local audience के लिए ज़्यादा useful होती है. I'm sorry if there was a problem in interpreting whatever I said. Well, now I'll be talking about genetic counseling for hemoglobin disorders in the local sociocultural setting. I'm not talking about the genetic counseling in general, but it's particularly with reference to our own sociocultural setting. Well, just to give you an idea what genetic counseling is, that it's a process. It's a sort of conversation between the person who is delivering that knowledge about a disease, and there's a person or a family who is actually in a position to receive that information. And when we talk of a genetic disorder, then the conversation probably is related to a genetic disorder in question. And here we are talking about thalassemia, and it's an autosomal recessive disease. And the purpose of this conversation is to help them understand the disease. I think this is very important, a very, very important aspect. We just look at yourself and look back. Let's say there's a pediatrician involved in care of thalassemia patient, then how much time do they spend with the patient in explaining that what thalassemia is? I'll give you an example. I think we can take up a little later. To provide information on resources for diagnosis, number one, then management, number two, and then finally prevention of the genetic disease. I think all these aspects of the disease, they must be discussed with that individual. And this is all about genetic counseling. Principles, well, international norms of genetic counseling are that it should be non-directive. You should not suggest something to the person who is receiving that information. You're supposed to explain everything to them and then expect them to make their own choice or decision. Well, using phrases like your child is sick because your cousins, I think this is the most, irresponsible statement that we make in our conversation. And in fact, when I get patients, they're already in a sort of discomfort zone that they would immediately say, कि जी हम cousin हैं इसलिए हमारा बच्चा बीमार है. And I always ask them, who has told you that? वो जी डॉक्टर साहब ने ये बताया. I think this should be avoided. Do not have further children. Well, this is another advice. In an era, fortunately, where we live in an era where prenatal diagnosis is possible, I think giving an advice against having more children, well, you're trying to restrict the freedom of the person. It's their own choice whether they want to have children or not. I think it's not our responsibility to suggest that. Then get the pregnancy terminated. This is another, I think, very important area where many a times we try to make this mistake, especially the obstetricians who are involved in care of individuals with, let's say, a fetus being affected by genetic disorder. Then we take onto our own selves the responsibility that getting the pregnancy terminated is perhaps my responsibility. No, it is not. It is the individual's own responsibility. He or she must be given that information, that how to go about it. Then confidentiality, this is another important aspect. But unfortunately, confidentiality is really, really difficult to maintain in our circumstances. यहाँ तो 10 बंदे एक clinic में इकट्ठे बैठे होते हैं and the person is delivering counseling. तो वो should be avoided as far as principles are concerned. Our socio-cultural setting, I think, important. We all know literacy is low and awareness is also low. Literacy and awareness, they go hand in hand. People who are more educated are likely to be more aware of a particular situation. But this is not exactly true. Sometimes we have very illiterate people who are actually very aware of a problem. So it is the awareness, I think, at the end of the day, which is important. You should not take for granted कि ये तो बिल्कुल अनपढ़ बंदा है, इसको क्या समझ आएगी. No, it is not like that. I have experienced it many times. समझ is not related to your literacy. Although awareness increases with literacy. Consanguinity and family structure. I think in genetic counseling, in terms of genetic counseling, this is one of the most important areas where consanguineous marriages, they are blamed for a genetic disorder. We need to clarify the situation. We know that there is an increased genetic risk for a person who is married to a cousin or, for that matter, any close relative. But this is not the end of the day. This is a custom which is here for thousands of years, perhaps. And we have to find a solution for that. Not discouraging consanguineous marriage simply based on our genetics knowledge. Then financial status, health facilities, logistics, urban, rural, they're all well-established phenomena. I think we need not talk about these. And let's talk about literacy and awareness. When a person or a child is diagnosed with thalassaemia, and for that matter, any genetic disorder, I think that family is devastated. They're really in a state of denial. They like to listen to something which sort of gives them hope. Hopelessness, I think, is the worst situation. Denial. They try to deny it. I have experienced it, not just related to thalassaemia. My son is affected by autism, and we have a small sort of an institution where we get a lot of parents with children having autism, and most of the parents, they are unable to accept it that their child is sick or it has a different sort of an health issue. So denial, I think, is important. That goes again to say that it is our responsibility to clear all of these things, all of these states, and the state of denial, and then this confusion. Confusion actually arises when you are trying to accept at one hand, and on the other hand, someone is there to convince you, or your own self is there to convince you that, no, my child is okay, there's nothing wrong with him. This actually leads to worsening of that problem. And helplessness, I think this is the worst kind of a feeling that you can have, that if you have a child and you are not able to find a resource for its treatment in time or adequate treatment, this is really a very, very unfortunate situation. आपने ये देखी होंगी ये चीज़ें जो लिखी हुई हैं, अब ये उर्दू है, इसको मैं उर्दू में ही पढ़ सकता हूँ, अंग्रेज़ी में नहीं पढ़ सकता. ये कैसी बीमारी है जिसका ना सुना है ना पढ़ा है. दिस इज़ मतलब ये आप सुनते रहते हैं. हमारे ख़ानदान में तो ऐसे कभी नहीं हुआ. यू टेक द हिस्ट्री इन दैट फैमिली, दे वुड ऑलवेज से कि जी नहीं हमारे ख़ानदान में तो कभी नहीं हुआ. इफ़ यू डिग इट आउट तो इट कम्स आउट कि जी नहीं हो चुका है, पहले भी हो चुका है. वही डिनाइल वाली बात है. अल्लाह मालिक है. आई थिंक दिस इज़ अ फ्रेज़, अल्लाह ही मालिक है हम सबका, ये तो इसमें कोई डाउट नहीं है. लेकिन इट इज़ सो अनफॉर्चुनेट दैट मैनी टाइम्स हम लोग इस चीज़ का सहारा लेके अपनी मिजरी में बहुत इजाफा करते हैं. ऐसे ही है. आई होप कि हम सिंह रब दी मर्जी है, अल्लाह करे सी. बट अल्लाह ही नहीं करना है इसमें, बट अल्लाह हैज़ गिवन यू द विजडम एंड अवेयरनेस एंड इट्स डॉक्टर्स रिस्पॉन्सिबिलिटी टू एक्चुअली एक्सप्लेन इट टू दिस कि जी अल्लाह ही करना है, सब कुछ अल्लाह नहीं करना है. लेकिन अल्टीमेटली यू आर द पर्सन हु इज़ एक्चुअली गोइंग टू मैनेज दिस चाइल्ड. एंड denial, confusion and helplessness, उसमें बाहर निकालना है उसको. Consanguinity and family structure, I think it's very important. This is a study published in early 90s by Mittles and his colleagues, and you can see that in Pakistan, literally only 16% of the marriages, they are truly unrelated. बाकी या तो they are within cousins or they are within the brotherly. Brotherly is also an extended family. As you can see in this family tree that there are a large number of individuals who are really related to each other. और इसमें अगर आप couples देखें तो 1, 2, 3, 4, 5 couples I can count, they are consanguineous. तो ये this is a sort of norm in these families. और इस norms को you should not try to break this norm. Let me tell you. अगर आप इसको तोड़ने की कोशिश करेंगे तो कोई फ़ायदा नहीं होगा. अल्टीमेटली एंड ऑफ द डे यू विल नॉट एंड अप एनीवेयर. इसके अंदर रह के देखना है कि क्या करना है. सिंपलेस्ट थिंग आई कैन टेल यू इज़ दैट लेट्स से इफ देयर आर 2 individuals इन दिस फैमिली हू आर टू बी मैरिड टू ईच अदर. कैन यू शो दिस स्लाइड टू. ये मेरी शक्ल नज़र आ रही है लोगों को या स्लाइड नज़र आ रही हैं? दोनों आ रही हैं. थैंक यू वेरी मच. ओके, दिस इज़ एन अफेक्टेड चाइल्ड, दिस इज़ अ फैमिली. And this is one individual who's a carrier, and if this person has to get married, then choice is कि ये लड़की के साथ भी इसकी शादी हो सकती है और इस लड़की के साथ भी हो सकती है, इसके साथ भी हो सकती है, ये आगे चलते जाए. तो I think consanguineous marriage करते हुए भी you can avoid marriage between 2 carriers if you know the carrier status in that family. So it's a very sort of a convenient environment in which the arranged marriages can be planned, and you can avoid marriage between 2 cousins. Between 2 carriers, and yet it can be a consanguineous marriage. This applies to every recessive genetic disorder in which carrier screening is possible. Thalassaemia fortunately can be diagnosed, the carrier status can be known just by a simple blood test, and it's a very, very powerful sort of a tool in which you can allow consanguineous marriage, and yet at the same time you can avoid the harmful effects of it. Well, this is what we actually do. अपनी हथौड़ी पकड़ते हैं. And this is what we usually do. कि जी आपका बच्चा बीमार है, your son is sick because your cousins. And this is a sort of statement, I think this is very, very damaging. At that particular stage, that couple cannot go back and get divorced. Are you trying to suggest that by blaming that your child is sick because you are cousins? ये कभी ना कीजिए. Please remember that. What we really need to do is this is my logo as well. ये मेरी जो lab है उसका ये logo भी है. Genetics Resource Center में यही है. We are here to actually provide comfort, to pray for you, and then take care of that particular family who is affected. Now this is the strategy. And carrier screening, I think, carrier screening and then allowing a cousin marriage based on the knowledge of carrier status. This is actually the solution. Issues in genetic counseling, some of them. Number 1, correct diagnosis. Now, I know that nearly 50% of the children that we get for investigation related to thalassemia, they're already blood transfused. And in that particular scenario, diagnosis really becomes an issue. And when diagnosis becomes an issue, that is your starting point. Pediatricians are unable to accept a result which is normal. A child who's transfusion dependent, who's chronically transfusion dependent, would have a normal hematology, a normal hemoglobin electrophoresis. वो करवाते भी ज़रूर है और जब रिजल्ट नॉर्मल आता है दे वुड से कि देखा मैंने कहा था दिस इज़ नॉट थैलेसीमिया. वेल दिस इज़ आई थिंक यू आर एडिंग टू कन्फ्यूजन. A part of counseling is that you should have the correct diagnosis, and then they would run for expensive investigations like PCR. टाइम पे नहीं करते, डायग्नोसिस नहीं होती, उसमें पेरेंट्स का भी कसूर है. And then doctors who are dealing with these samples, lab people, they are also at fault. They would like to give results without looking at the patient, and that creates confusion. What is thalassemia? I think it is important to explain to the parents. I know, I remember a small incidents when I was, I think, a colonel. I was in AFIP. मेरे clinic में once a couple came from Gujranwala. It's my habit. I usually take some time and try to explain to them that what is this disease. I was explaining to them what thalassemia is, and I noticed that the father had tears in his eyes. So I got upset. I asked him that what's wrong? Did I say anything wrong? कहते नहीं जी डॉक्टर साहब मेरा बच्चा 7 साल का हो गया आज मुझे पता लगा इसको क्या है. मेरे लिए वो वाक़या अभी तक मुझे याद और नहीं बोला. ये हमारी आई थिंक अनफॉर्चुनेटली मिस्टेक है. इट्स आवर मिस्टेक. वी डोंट एक्सप्लेन, स्पेशली जब बिजी क्लिनिक में बैठे होते हैं. दी पीडियाट्रिशियन दे हैव द रिस्पॉन्सिबिलिटी. अब हेमाटोलॉजिस्ट ज़्यादातर थैलेसीमिया को नहीं देखते, बट पीडियाट्रिशियंस आई थिंक इट फॉल्स ऑन देम दैट इट्स देयर रिस्पॉन्सिबिलिटी. एटलीस्ट किसी जूनियर हाउस ऑफिसर को इस काम पे लगा दे. वी शुड एक्सप्लेन टू द पेरेंट्स. It becomes, the whole lot thing becomes easier to face when you know that what's wrong. That management becomes easier because it's a lifelong management. And they would expect कि जी ये तो ठीक हो जाएगा बच्चा, कुछ इसको 1-2 ब्लड लगेंगे उसके बाद ये ठीक हो जाएगा. नहीं, it is not like that. Unless you explain it to them that this is the disease and this is a lifelong disease. And you have to face it for the rest of the life of the child. Then resources for management. इसमें मैंने आपको दिखाया NGOs दे आर नियरली 90% काम उन्हीं के पास है. तो whenever you diagnose a child you have to send that child to certain place. अब it's your responsibility to tell them कि जी which NGO is better and which is not. वो अदरवाइज़ किसी और के जाल में फंस जाएगा, जाके हकीम के पास चला जाएगा, कुछ करेगा, कोई अल्टरनेट फॉर्म ऑफ ट्रीटमेंट ढूंढेगा. प्रिवेंशन ऑफ थैलासीमिया की चॉइसेस, आई थिंक काउंसलिंग में हम सबसे इंपॉर्टेंट वी थिंक दैट प्रिवेंशन इज परहैप्स द मोस्ट इंपॉर्टेंट थिंग. आई थिंक इट्स इक्वली इंपॉर्टेंट कि यू हैव टू एक्सप्लेन टू दैम दैट हाउ टू अवॉइड दिस डिजीज, हाउ दे कैन एक्चुअली अवॉइड द बर्थ ऑफ अनदर चाइल्ड इन द सेम फैमिली. तो रिसोर्सेज के लिए द NGOs आर अवेलेबल, पब्लिक सेक्टर हॉस्पिटल्स आर अवेलेबल, प्राइवेट हॉस्पिटल्स भी हैं इफ द पेशेंट्स कैन अफोर्ड, एंड देन अल्टरनेट फॉर्म्स ऑफ ट्रीटमेंट. ये आई थिंक आई वुड लाइक टू ऐड टू दिस कि ये अल्टरनेट फॉर्म्स ऑफ ट्रीटमेंट आर अवेलेबल. फॉर एग्जांपल हाइड्रोक्सीयूरिया इज वन ट्रीटमेंट. इफ़ यू आर पर्सनली बायस्ड अगेंस्ट दैट तो प्लीज़ डोंट शो दैट बायस टू द पेरेंट्स. ठीक है, मैं आई accept that responsibility. I'm not in favor of hydroxyurea treatment for general treatment of thalassemia major patients, but that is not my responsibility. I should explain it to the parents in a way that, look, this form of a treatment is available which is good for a certain category of patients who have a milder disease, not for all patients of thalassemia major. बट आई शुड नॉट हैव अ स्टिक इन माई हैंड किसी कि ये हाइड्रोक्सीयूरिया तुमने लगवाई तो तुम खुद जिम्मेदार होगे. नो, इट इज़ नॉट, इट शुड नॉट बी लाइक दैट. यू हैव टू एक्सप्लेन इट टू द पेरेंट्स दैट दिस इज़ अवेलेबल, दिस इज़ द बेनिफिट एंड दिस इज़ नॉट द बेनिफिट, एंड देन लेट द पेरेंट्स मेक द चॉइस. काउंसलिंग में, नॉन डायरेक्टिव काउंसलिंग में आई थिंक इट इज़ इम्पॉर्टेंट कि हमारे चूँकि लिटरेसी एंड अवेयरनेस कम है तो इट्स आवर रिस्पॉन्सिबिलिटी एटलीस्ट टू हेल्प दैम इन मेकिंग ए चॉइस. ऑल्दो चॉइस शुड बी परमानेंटली या टोटली उन्हीं का होना चाहिए अपना, बट हमारी रिस्पॉन्सिबिलिटी है कि वी शुड मेक इट ईजियर फॉर देम टू हैव दैट चॉइस. प्रिवेंशन, देयर आर 3 पार्ट्स. नंबर 1 कैरियर स्क्रीनिंग, एंड देन सेकंड इज़ प्रीनेटल डायग्नोसिस. काउंसलिंग को हम वैसे ही कहते हैं कि ये तो सिर्फ काउंसलिंग में ही होती है. काउंसलिंग इज़ ऑल्सो इंपॉर्टेंट. ये जो मैं इतनी देर से झक मार रहा हूँ या बैठ के बता रहा हूँ आपको, दिस इज़ व्हाट इट इज़, काउंसलिंग है. तो दिस इज़ इम्पॉर्टेंट. इसमें कुछ नुक्ते ऐसे हैं जो विच आर वेरी वेरी इंपॉर्टेंट. कैरियर स्क्रीनिंग के लिए अप्रोप्रिएट स्ट्रेटजी, वो तो ज़ाहिर है ऑब्वियसली वो हमने देखा है कि इन दिस कंट्री फॉर्चुनेटली एक्सटेंडेड फैमिली स्क्रीनिंग परहैप्स इज़ इम्पॉर्टेंट. लेकिन उसके अंदर भी देयर आर मोड्स कि जिस तरह से इसको किया जाए. बहुत सारे तरीके हैं. वी आर अ रिसोर्स कंस्ट्रेंट कंट्री, इसमें कोई शक नहीं है. मैंने पहले भी कहा था रिसोर्स की कमी नहीं है, लेकिन डिसऑर्गेनाइजेशन है जो कुछ भी है. बट स्टिल आई थिंक अगर आपके पास पैसे लिमिटेड हैं तो ट्राई टू अडॉप्ट समथिंग विच इज़ कॉस्ट इफेक्टिव. Stigma, I think this is very important, and it is our responsibility. Normally what I do is that I try to tell them, let's say there is a young man who is found to be a carrier of thalassemia trait. He gets worried. So it's normally I tell him कि आपको शुक्र करना चाहिए कि आपको thalassemia trait है. वो एकदम हैरान हो जाता है, ये कैसे? You would not have falciparum malaria. You are immune to that, number one. Number two, ischemic heart disease, chances are less as compared to the rest of the population. Diabetes perhaps is another thing. जिसमें कहते हैं कि thalassemia carriers को there is a lesser incidence. So there is a way of looking at it. This is the bright side of the story. It's again your responsibility to explain it to the parents or patients or whatever. Confidentiality, I think important बहुत ज़्यादा है. But when you're doing extended family screening, तो वहाँ तो चटापटा सब कुछ खुल जाएगा ना, वो बहुत ज़्यादा है. वो उसमें it's very tricky. तो एक फैमिली के अंदर तो बहुत chaos मच सकता है. I think what I have noticed और मैंने जो एक्सपीरियंस किया है वो ये है कि जो फैमिली एल्डर्स दे शुड बी टोल्ड अबाउट एवरीथिंग बिकॉज मोस्टली दे आर द वंस हु मेक डिसीजंस and rather than explaining to individuals in that family, the family elders who are actually responsible for taking decisions, they should be explained. Okay, this person is affected, they are carriers, and whenever you are trying to arrange a marriage, please take into account that. So confidentiality is a very relative term in terms of extended family screening. Risk calculations we hardly ever make. Remember that अभी कल I was listening to वो मदनी चैनल है उसमें एक मौलवी साहब थे वो तकरीर कर रहे थे अपनी थैलेसीमिया पे तो he was saying कि when both parents are carriers तो बच्चे में 50% चांस होता है वो थैलेसीमिया मेजर होगा वो ऐसे नहीं है 25% है so remember that तो ये कैलकुलेशंस आपके लिए इंपॉर्टेंट है व्हेन यू गिव दिस इन्फॉर्मेशन तो रिमेंबर ये इन्फॉर्मेशन इज़ एक्चुअली उनकी दिमाग के ऊपर छप जाती है जाके वो फिर उसके बाद एंटीबॉडीज़ बन जाती है इसके अगेंस्ट तो वो फिर दैन डिसेंसिटाइजेशन इज़ वेरी वेरी डिफिकल्ट प्रीनेटल डायग्नोसिस व्हेन एंड वेयर अर्ली प्रीनेटल डायग्नोसिस इज एनकरेज्ड ठीक है 17 वीक्स तक 16 तक वी डू प्रीनेटल डायग्नोसिस बट अर्लियर द बेटर और कहाँ से करवानी है वो आपने एक्सप्लेन करना है टाइम और किस जगह से करवानी है वेर एवर यू आर कॉन्फिडेंट दैट द पेशेंट विल बी बेनिफिटेड वहाँ भेजें उसको अनाड़ियों के पास ना भेजें सो दिस इज़ इम्पॉर्टेंट टर्मिनेशन ऑफ प्रेगनेंसी फतवा इज़ अवेलेबल आई थिंक मेरे लिए ये बड़ी रिवॉर्डिंग चीज़ है कि जब मैं when we get patients who are anxious about termination of pregnancy, I usually explain it to them. और एक written पर फतवा इसकी copy should be available with you. कि मौलाना तकी उस्मानी and his verdict, the religious verdict is available and that really is helpful. And you should be able to explain it to the individuals. Then awareness campaign, I think personal communications or lectures, information brochures, leaflets, videos, pictures, or all such a long list of individuals. I actually suggested that thalassemics should have, or the thalassemia community should have a channel of their own, TV channel, where they should be able to communicate freely. Probably commercially may not be viable, but I think this is an idea which was floated, maybe a YouTube channel or something like that, which can be very useful. It can be very helpful. And that's all about it. I hope I've been able to communicate the message. And again, I'm really grateful to PC and PSH for giving me this opportunity. And if there are any questions or comments, we can maybe perhaps take it at the end. Thank you very much.
Thank you so much, General Suhaib. It's been again another enlightening talk from your side. Now I would like to invite Dr. Shahtaj Masood Khan. She's a professor at Khyber Medical College, Peshawar, and she is currently supervised 26 FCPS graduates. And she has also received the Presidential Award for Thalassemia Care on 8 May 2019. She will be talking about evidence-based iron chelation in thalassemia major. Dr. Shahtaj, please.
Thank you very much, PSH, for giving me an opportunity to talk on this forum. So here it is. Today I'll be talking about iron chelation in thalassemia major, a topic of my choice. I'm so happy to be here because General Suhaib, the pioneer, is here today. The session was started with my trainee. Then we have Dr. Shabnam in this session. People confuse me for Dr. Shabnam, so she calls me Shabnam and I call her Shahtaj. And the fourth is Shabneez. So the 4S here today. Starting with the topic, how is iron absorbed from the body? Our body has iron stores of about 200 to 1500 mg, and most of it is absorbed from the senescent RBCs. It's absorbed in the enterocytes in the form of ferric, and then converted to a ferrous form inside the enterocytes, and the absorption is about 1 mg per day. Then that plasma circulates in the form of ferric form again, and in the form of plasma transferrin. Hepatocytes may be interconversion hoti hai from ferric to ferrous. Finally, the iron enters the erythroid bone marrow, where it is utilized by the red blood cells for production of red blood cells and the hemoglobin of red blood cells. There is a loss of 1 mg per day from our body. The rest of the iron is taken up by the macrophages as stores. So the normal iron stores are taken up by the macrophages, and up and above the normal, the excess iron is also taken up by the stores. In case of hypoxia or chronic anemia or ineffective erythropoiesis, both the kidney and the liver come into play. There is increase in erythropoietin and increase in ferroprotein. In the liver, there is decrease in hepcidin whenever there is hypoxia or chronic anemia, which leads to increase in GI iron absorption. The release of recycled iron from reticular endothelial macrophages is also there. Why is there iron overload in thalassemia? Because of the previously said, the chronic anemia and hypoxia, there is increase in absorption from GI. The patients are regularly transfused, and there is about 200 mg of iron per bag. And as we said earlier, that only 1 mg per day is excreted normally. So transfusion and GI tract accumulates about 0.3 to 0.4 mg iron per day. And whenever there is an increase, we can see it again in this slide, it goes into the plasma transferrin level site, and the free radical of irons in the form of labile plasma iron is there whenever the transferrin saturation is more than 70%. Now, what are the iron overload complications? Initially, in the first year, 10 years of life, the iron level keep on increasing. We say that around 15 to 20 transfusions of blood will increase iron levels to above what is normal, and the complications keep on increasing after the age of 20. The patients are symptomatic between 10 to 20 years. There is a growth delay, hypogonadism, hypothyroidism. Diabetes is common in these patients. There's osteoporosis, and because of that, along with growth delay, there is stunted growth. The liver fibrosis give rise to so many features, and of course, if there is also hepatitis complications, like the transfusions of unscreened blood, if the patient has hepatitis B or hepatitis C, there is increased tendency for liver fibrosis along with the increased iron concentration. Arrhythmias happens, and there is cardiac failure and ultimately deaths. So the patients actually don't die of thalassemia, but they die of the transfusion-related complications or the ineffective chelators. So for that reason, we have been using iron chelation therapy. And what are the goals? It is to maintain an actual iron balance and to avoid accumulation of the redox active iron, which was as we said earlier, if there is more than 70% saturation of transferrin, that will lead to increase in redox active iron. Giving chelating therapy may reverse the actual organ damage, and if there is no organ damage till time, it will prevent or at least postpone it. We have to look into the chelation toxicity. We have to see maximize compliance. That is how we prescribe therapy, so that there is compliance, because it's a lifelong morbid disease. Our goal is to prolong survival and improve quality of life. So decreasing morbidity and mortality is our ultimate goal. What is the target serum ferritin level? It is in non-thalassemia dependent patient, non-transfusion thalassaemic dependents, we like to keep the iron level, serum ferritin level below 1000, but in thalassemia major, we would like to keep it at the level of 1000. Whenever it increases below 2500, there are more chances of morbidity of the liver involvement, heart involvement, etc. But what we see in our setups, in the government setups, is that, of course, the ferritin level is far much above this value of 2500. So the target value is less than 1000, which is recommended by Thalassemia International Federation. And when the values are more than 2500, it is associated with increased risk of cardiotoxicity. Unreliable ferritin is unreliable because, especially in the current COVID situation, we have come up with sudden increase in iron levels, serum ferritin levels, and when we investigated those patients, they were COVID positive, especially the adults one. And so at this stage, the iron levels, or if they are suffering from fever, so it's an acute phase reactant, it becomes unreliable. Otherwise, it is ferritin is the method of regulating iron therapy. What are the available irons in the market? These are desferoxamine, deferipron, and deferasirox. These are the three available iron chelator in the market throughout the world. Now, when did they become available? In the 1960s, these thalassaemic patients started to have regular transfusions. And in the 60s, TFO came into clinical use, desferoxamine, and it is a subcutaneous drug. So from 60s to 80s, this was the only drug available. In 1999, deferipron was approved by European Medicine Agency, and it came into the market. Then in 2005, DFX was approved by FDA, and in 2006, it was approved by European Medicine Agency. So these were the drugs available from 2005 and 2006 onwards, and in 2011, deferipron was approved by FDA. And there are many results of the phase 2 trials. What is desferoxamine? It's actually a hexadentate molecule, and it's excreted through urine and feces, but the use is parenteral. It is very effective in regulating high doses of iron, and when we are not being able to control it with a single oral dose monotherapy, that is where we end up in giving these subcutaneous injections, which was, of course, the first one to be available in the market. But after the availability of the oral forms, this has become a second line of choice. Of course, there are many side effects of this drug. The ototoxicity and renal toxicity are the major side effects, which should be regularly monitored. And there is growth defects and bone abnormalities. Because the plasma clearance is very short, that is 20 minutes. So it has to be given over a prolonged period of time. And what we are regularly using is giving it 5 or 6 days a week, because these patients also needs to get rested. And it is transfused over a long 8 to 10 hours subcutaneously. Then came deferoperon, which has a plasma clearance of 1 to 3 hours, and the daily dose is 3 times a day, with a clinical experience of more than 25 years. And the most common complication is agranulocytosis. Initially, we were giving it, but we saw many leukopenias and arthropathies. So at our end, we have stopped using this drug. It also gave GI disturbances. So it is available, it is in the market, it is cheaper than the other drugs, but the dose is 3 times a day and with these complications. So those who cannot afford desferoxamine or deferasirox, this is the drug of choice for these patients with the availability and cheaper costs. Then we had the deferasirox. This was an oral drug introduced, and the plasma clearance is high, 1 to 16 hours, so it's given once a day. And the excretion is through fecal routes with a clinical experience of more than 15 years. The most important side effect of this drug is rising serum creatinine, and we have noticed that. That's why it is mandatory to see the serum creatinine at least in 3 months' time, but recommended on monthly interval. It is given once a day. So when deferasirox was there, it has a multi-step preparation. It cannot be taken with food, should be taken before the food, and there is a large chalky fluid which causes the administration difficult in small children, and there are many tolerability issues, the GI disturbances, nausea, vomiting, and all these type of complications. The latest introduction of film-coated tablet has issued and we have given it in certain patients. Here I would just add that because we had the chelator in the oral form already available in our hospital, so whenever we asked the Baitul Mal, it was not allowed by our management because we had this. So those who had already filled the Baitul Mal forms and they had to run from here and there and get it done, those patients wanted the drug. So the other alternative was to get the film coated in place of that, and it worked, especially in children 3-4 years. It did work very good. I still have a child with us, and she said that the baby 3 years old is fond of eating the younger baby's Cerelac, so she puts in on that, and for the past 4 months she has been giving it without any complications, and it is definitely it is better than when dissolved and given on empty stomachs. So this is the latest updates on chelator therapy with a film coated tablets introduced into the therapy. What are the benefits? It's ease of administration, no need of preparation, patient convenience, and lesser side effects. The dosages are also decreased, and this is a chart showing if the patient was taking 40 mg per day, he has come down to 28 mg per day. So the cost is almost the same with an easier way of taking the tablets. So in these tablets are begun with a dosage of 14 mg per kg when serum ferritin is consistently more than 1000, and it can be increased to 28 mg per kg if the ferritin is persistently above 2500 and not decreasing over time. It's easier to administer, convenient and available, effective with lesser side effect, cost effective, and monotherapy. So these are the side effects of the subcutaneous iron: pain at the injection site, evening social life is disturbed, the work capability is disturbed, and above all, there is frustration, anger, depression, and sadness. And of course, sleep disturbances are there because of carrying the pump with them. A study in North America and Italy shows that there is increase in life expectancy in these patients, and they have started to survive above 40 years of age now. But with the increasing age, there are certain problems that we have to look into. These are the fertility and pregnancy, adherence to therapy, transition from pediatric to adult health care, quality of life, and other age-related complications. Initially, the life expectancy was around 17 years in 1970s, and in the 80s it went to 27 years, and in the 90s to 37 years, and now to more than 40 years. Of course, those who are getting transplanted, they have a almost normal life expectancy. Multidimensional issues, patient-related issues are attitude and benefits, therapy-related factors, palatability, fed versus fasting state, adverse effects, conditions related acute and chronic, and demographic factors, socioeconomic issues, the expense of the drugs are to be brought into consideration. The average patient's compliance, WHO reports that 51 patients with antihypertensive patients, 51% will be taking the medicine regularly. So this study was conducted, which shows that the patients are non-compliant with taking the medications regularly. So the Thalassaemia Federation, International Federation, stated in 2014 that the second major challenge in chelation therapy is to achieve regular adherence to treatment regimes throughout a life, as even short periods of interruption to treatment can have damaging effects. And if there is adequate adherence, there is increased overall free survival and overall life, a decrease in mortality and morbidity. Only 59 to 78% of patients met the defined criteria for adherence to deferoxamine in clinical studies. So even in the older times of Hippocrates, 460 BC, he said that patients often lied about their medicine. So how should we improve the adherence? By shifting the patient to a convenient chelator. Behavioral rewards, जो कि हमारे लिए बहुत मुश्किल है. Programs and counseling, again a difficult issue. Pill counting, that yes, that we do. We take back the strips, and motivations. Every chelator has its challenge and side effects that I have mentioned earlier as well. Reasons for non-compliance is because of the chronicity, and they don't see any immediate effect, and they don't see any harm by stopping it there and then. They don't see anything. That's why they don't feel like adhering to it. They can forget to take the drug, and the cost of the drug comes in a major issue. This was a trial that was done on a group of patients for 1 month, and the most common effect before switching from the injectable to oral was that most of the time the patient were not, most of the time, that was 31% of the patient were compliant. When they switched from injectable to orals, that group changed to almost 70%. So it improved the overall adherence to the therapy. So we have to give education, behavioral skills, effective support, and caregiver involvement. Monitored by therapeutic effect and adverse reactions. Serum ferritin is the main source of monitoring. Of course, liver structure functions, the LFTs and everything has to be done throughout for monitoring of these patients. The baseline investigation should be done at the admission and on monthly basis. The creatinine, urine proteins, and serum transaminase and bilirubin to be done monthly, and auditory and ophthalmic functions to be seen as a baseline and then annually. The aim of providing these facilities under one roof is to provide a safe transfusion, iron chelation, screen blood, to assess the growth, to have dental assessment, liver and cardiac assessment, and psychosocial issues, and that is what Hyderabad Medical Complex is providing to these patients under one roof. So, summing up, transfusion and chelation therapy have improved the quality of life and expectancy in thalassemia patients, but of course, at the same time, prolonging life has brought many issues with it, like fertility, like marriages, like stunted growths, etc. There are challenges to adherence, and adherence to iron chelation therapy ensures that desired outcomes are achieved. Advanced iron chelation therapy have helped improve patient convenience and satisfaction, and oral chelation has been associated with better adherence than parenteral route. With that, I end my presentation, and if any questions I can respond to.
Right. So we are. Thank you so much, Dr. Shahtaj. It was a very, very enlightening talk, and we'll now take the question and answers for all the sessions. But before that, I would like to introduce the panelists. We have Dr. Ghulam Nabi Kakepoto, Dr. Nadir Ali, and Dr. Muhammad Nadeem. Please, we have up till 12:40 till we can take question and answers. So let's start.
I am Dr. Nadeem. I have a question for General Suhaib. Yes, sir. My question is that I agree with you. You are very right on target when you say that our stress has been during the last many decades for the management part, especially the NGOs. The reason is that they are able to get more donation to their donors. That's one of the reasons. I think, and the screening part is not that much glamorous, so that they are not able to get the fund. My question is about your stress on extended family screening, sir. Do you have any statistical model which can show that we will be able to decrease the thalassemia major population drastically by follow this model? Because my understanding is that most of the countries, those who have achieved this objective, they have achieved this by screening, population-based screening, not by adopting this extended family screening or following this prenatal diagnosis.
Well, what I have understood from your question is that you want to know about any previous experience or a model which actually has used extended family screening for prevention of thalassemia.
Or you have devised any, or do you have any statistical model which you have devised to follow?
Well, obviously, the short answer to your question is that no such actually model or even a statistical calculation actually exists. But let me tell you that the role of carrier screening as such, I've already actually said in my presentation that it is not as we expect it to be. Carrier screening is important, but probably only a smaller part of the entire exercise. Even in the Mediterranean countries, carrier screening alone was not enough to control the birth of thalassemia major patients. It was the prenatal diagnosis, when it was added to the scenario, that actually brought the incidence of thalassemia major down. And prenatal diagnosis in this country, basically we get two types of patients. Number one is who already have children with thalassemia major, and the second group is the one who do not have yet thalassemia major patients, but they are potential high-risk couples. In extended family screening, I think we have a golden opportunity of identifying such couples who have not yet given birth to children with thalassemia major, but they are actually potential users of prenatal diagnosis. Well, ultimately, I see no reason, although we have no statistical model on papers at least, but I see no reason that if thalassemia community They're practicing consanguineous marriages, and we have repeatedly proven by doing several extended family screening exercises. For example, Punjab Thalassaemia Prevention Program, I think they have screened thousands of families of thalassemia, and they have come to know that 30% of the individuals in these families, they are carriers. Then I see no reason why it should not be successful. Although we cannot quantify that amount of success, perhaps this is what you exactly wanted to know. Well, somebody can actually sit down and do some statistical calculations as well, but certainly common sense actually demands, or it makes us really believe that this perhaps is the most cost-effective approach as far as identification of carriers is concerned, and secondly, as far as identification of couples at risk is concerned. I hope that answers your question. Thank you.
Yes, my only concern is that establishing prenatal diagnostic centers is not also a very cheap option. It's quite effective, quite costly, and you know better than me that you need training, you need equipment, you need manpower, and so on. So why not? We should not only stress on prenatal diagnosis or extended family screening, but we should also talk about population-based screening. Because when a person like you, sir, talk only about extended family screening, it gives a message to general population, definitely. That's the only option. We should not go for, and similarly, we should not go for the mass screening or mass population screening. And already our many assemblies have passed this rule about this carrier screening before the marriage. That has gone on the background. So when you talk about this, not any other person, when you give this message, it has a very strong effect on the general population, even on we hematologists, as we take your advice very seriously.
Thank you very much for acknowledging that people listen to me, and I'm really delighted to know that. Well, carrier screening, let me take the question of cost of prenatal diagnosis. I think it's important to realize that cost, although Punjab Thalassaemia Prevention Program, they're offering a free service, so you can't have anything better than that. But even if the patient has to spend, let's say, 10,000 rupees for prenatal diagnosis, now this is a life-saving test that this couple will have to use maybe 3 or 4 times at the most in entire life. So this is not enough cost. I think एक बंदा जो है वो अपना खाना पीना बंद कर दे, but should try to get prenatal diagnosis. This is not enough. मतलब ये बहुत ज़्यादा cost नहीं है. I don't accept this idea कि ये cost ज़्यादा है, because the benefit is so much.
I'm not talking about the individual. I am talking about the development or establishment of the center. That's something different, sir. This establishment, you need funding. You need funding from, whether it's funding from the NGOs, whether from the donors, or whether from the government. Will anybody be able to fund this much amount because it's not 1 or 2 centers or maybe 10, 20 centers are not going to fulfill this requirement. We need a large number of centers throughout the country.
Obviously, but this is the only way out. Unfortunately, this is the only way out. Otherwise, I wish we could have a dipstick test in which आप urine में एक वो dipstick लगाएं and you get to know कि ये fetus affected है या नहीं. Maybe sometimes technology comes in, but for the time being, this is the only way we can get. If you weigh the balance, make an equation between the cost of establishing centers for prenatal diagnosis and on the other hand, the amount of money that you're spending on treatment of these children, I think there's no comparison. It is not even, I think, 5% of the total cost that you will have to spend in establishing center for prenatal diagnosis. इसके अलावा I think कोई चारा नहीं है. महंगा है तो अब क्या करें फिर? We'll have to do it. Otherwise, तो probably I am sorry taking too much time. This was because one of this statistical model was developed by Dr. Muin Maroon from the Buckeye Medical University. Mm-hmm. He made a statistical model for the screening of population of Sindh. And I think that was not very expensive. I don't remember the exact figure. It was not much. But somehow he was not able to get it through the Sindh government. And I think why not we should, no doubt prenatal is very important. We should also add this population-based screening or carrier screening देखिए, I think it is important. हाँ, अगर ये message गलत गया तो probably we need to correct it. At no stage I have actually said कि जी general population में screening should not be done. It can be done, it should be done. Why not? It should be voluntary. ये नहीं हो गया आप निकाहनामे में भी उसको डाल रहे हैं और इस तरह की चीज़ें करने की कोशिश करेंगे तो probably that would be counterproductive. इसमें screening voluntary basis पे होनी चाहिए and it should be done. Whosoever wants to get tested should be tested. लेकिन I think common sense approach is that we have done a study in which we studied the affected families and then we also studied the unaffected family, and we found that there was a hell of a difference between the prevalence of thalassemia in one group and the other group. So why should we actually be spending our efforts, money and everything on people who actually don't need it at all? इसका statistical model, yes, we can make it. If someone wants to do a research on papers and do calculations, so it can be done. But common sense demands, I think I think I am quite convinced. लेकिन अगर question आपको लगता है तो then you can find some individual who can actually do this calculation. Mathematician को ले, वैसे mathematician अगर इसमें आपने डाला तो सब कुछ ही तबाह हो जाएगा. Thank you.
Thank you, sir.
I have a small comment on this. Basically, we all are in one direction about the thalassemia, but unfortunately our efforts are not in one direction. The only answer to this problem is that at the government's level, we should ask for an authority, thalassemia authority at least. And we all, the experts, sit under the umbrella of this authority and make some policy about this thing. In which direction we have to go and what are the finances available, what are the rules and regulations for the screening of the people, what are the rules and regulations for the treatment of the people, and where to, how to distribute these resources. So I think we should, at one umbrella of PSH, we should start thinking about making an authority at the government's level for the thalassemia control.
I'll just add to say thank you to all the speakers. They were very excellent talks by Suhaib and Shabnam and other speakers.